One thing that we sometimes don't talk much is autonomic dysreflexia. And it's generally something we see mainly in a hospital, but I have a couple of patients I've been following as outpatient that have had incomplete cord lesions. And they're actually doing well from a myelopathy standpoint, but they have symptoms of autonomic dysreflexia, albeit partial. And one of my patients is definitely one of my most difficult one management-wise, definitely sensitive to any time she distended her bladder, which the biggest problem is at night, because during the day she has learned that every time her bladder is getting beyond a certain level, she starts to have spikes of hypertension. So the problem is at night. She cannot really get up every 2 hours to empty her bladder on a schedule. So, and most of the time the management is truly by avoiding whatever the trigger is. So like in her case, bladder fullness, which is a very classic one, is the thing. Other times, for those that are more complicated patient, more damaged, I should say, could be an issue of wounds that are not recognized because they are insensitive. So that really is the key. Years ago, there was this study showing what the filling of the bladder, which is, here it is, okay. Infusing fluids in the bladder, what does to the blood pressure and heart rate. And really there is a critical point for every patient beyond which blood pressure and heart rate goes out of control. And here you simply see a spontaneous event. A patient was just had a cough. And look at how dramatic the changes are. So these are patients that are really behaving as if the system is anarchic. And okay, maybe it's not a politically correct statement, but that's really what happens. And so you can try to control with medication these events as much as you want, but if you try to act on the actual trigger, you're obviously much, much more successful. I guess the key generally is try to identify what these triggers are and act accordingly. Depending upon where the lesion is, the pathophysiology differs, but the end point is always the same. So acting on treatment, as I mentioned, prevention is truly the best thing. Some of these patients have a range of blood pressure spikes that are truly hypertensive emergencies. So you need to act with the short-acting medication, sublingual, things like that, etc. But really try to work hard in trying to prevent whatever the trigger is. And another typical drug that we use for these are clonidine, which is still probably one of the best. Baclofen, not directly, but indirectly, in the sense that some of these patients will develop the dysreflexia reaction to painful spasm, muscle spasm, secondary to the myelopathy and the spasticity. I personally never had much luck with tizanidine, but some people love it. I don't know what you guys, Tom, if you had much experience on that. I find that generally, if baclofen doesn't work, tizanidine doesn't stand a chance. And after all, it's less powerful than clonidine and baclofen combined. So I don't know what your experience has been.
I've certainly found it to be effective in particular situations.
I don't know.
As an add-on.
Yeah, okay. Just almost never I found it alone anyway, but I personally definitely like a clonidine and baclofen much more. If the patient has problems with pain being a trigger, which is another common trigger, then you can try with the typical neuropathic type drug agents of any kind. And I don't have a preference one over the other. Pretty much is a trial and error. For vascular hypersensitivity, again, generally topical nitroglycerin is effective, or prazosin, which is, of course, is another alpha agent. Nifedipine, I have not used it much sublingually. I don't have much experience with it myself, but it's been another drug that has been reported to be quite helpful. In terms of the chronic management, the key is generally controlling the triggers, and usually the first target are bladder and bowel. No question about it. Once you're done that, I would say you are 50% done. Then you'll have to manage whatever is left with wounds, intercurrent infections that you may not suspect. I had a patient with cholecystitis, which was painless because the patient was deafferented. So sometimes may require a little bit of work to identify this patient because, again, of the lack of sensations. Anyway, enough of that. I don't think I have specific slides regarding the central autonomic storms. How different do we treat them? They're generally more complex cases because we're talking hypothalamic disorders, generally either with due to trauma. I had a few patients that had it after tumor removal, radiation, things like that. The management drug-wise is still the same. Generally, clonidine is a drug of choice. Opiates can be very helpful. And then various agents, the same agent essentially for blood pressure control. Yes, and bromocriptine too, yes. And if they have also the problem with the temperature dysregulation, dantrolene sometimes still is still a drug of choice, although it's a drug that's rarely used these days.
You ever use, I haven't done this myself, I was just curious, have you, because some of the patients with MSA have such severe supine hypertension and orthostatic hypotension, have you ever tried bromocriptine in that situation?
No, I have not.
Or I have tried clonidine.
I've used clonidine a few times, but the problem that I had is that works for the night, but usually carryovers during the day. And so, I mean, it's a drug that I personally like a lot, but I find it as too long acting for most patients and carries over through the morning. Specific entities otherwise in terms of central autonomic problem, end stage in multiple sclerosis particularly, they seem to have problem with hypothermia. Very difficult to control. We really don't have a good way to raise body temperature unless you poison the patient, obviously. So generally it's an issue of external means to heat the patient up. I had a patient that if we don't give them anything, I mean, if you don't warm them up, their body temperature drops to 34 Celsius. If the patient, occasionally I have a patient that complains that they feel cold and they are more comfortable in room temperature at, let's say, 75, 80 degrees. Even if I could not document an actual hypothermia, I find a medication of the group of the SSRI can help them because usually make you feel warm. So Paxil, things like that. So it's a little bit cheating the system, but that could be helpful. Otherwise, there isn't really a good way. Otherwise, you have to give a person, I suppose, a mitochondrial toxic drug to create the inefficiency and generating heat. But I mean,
I used low-dose cytomel, low-dose T3.
Huh?
Low-dose T3.
I've not done it unless the patient has some evidence of, thyroid being deficient. You'd use it at homeopathic dose, basically.
Yeah, 25 micrograms.
Yeah, well.
And it seems to do a pretty good job getting people to warm up.
Oh, that's nice to consider.
The problem is that once you have a thyroid deficiency, then the endocrinologists take over and they say never use T3.
So we're always we're always an oddball. And of course, there are some autoimmune disorder, paraneoplastic, whatever, like Morvan syndrome, etc. And the new anti-potassium channel autoantibodies. We have 2 patients that we have been following at Mayo. I'm not primary on them. The autoimmune neurologists are primary. I got involved because of the autonomic management. Both of them were basically in a hospital in a coma with encephalopathy and bad autonomic storm. I'm talking really bad. Treated with immunotherapy, improved some, by no means to a normal level. They are semi-functional human being now, but still with cognitive changes, and still with autonomic dysreflexia that's been a nightmare to treat. I threw them the entire pharmacopoeia, and they are continuing immunotherapy. Immunotherapy seems still to be the best to try to control them, but again, N of 2, these are very rare cases.
Do you know which antibodies?
Was against the potassium channel. Anyway, we talked about the Parkinsonian disorder. Actually, Tom has already done that, so let's focus on the management. One thing always, obviously, well, I have this sleep disorder, so I'm talking about it, although this is certainly not the number 1 problem. But in the past, we used to lose patients with MSA at night because of central apnea, central hypoventilation, before we realized that that's what happened. So we do pretty much routinely polysomnogram in these folks. What stage? Most of us now, we do it one at baseline. Otherwise, I definitely always ask for partners to tell me if the patient has stridor. And at that point, the patient is pretty much guaranteed to have a sleep study and consideration for tracheostomy, obviously to protect them from dying in their sleep. Make sure to stay on top of the sleep folks, or I shouldn't say the sleep folks. They are usually very well skilled on this, but sometimes primary care physician just order an overnight oximetry. They see the patient has desaturation. They put them a CPAP. Wrong thing to do if you have central hypoventilation. So that's so make sure that the patients are checked for the question of hypoventilation, not CPAP. That's not the answer. Even BiPAP sometimes is not the answer. They really need eventually a tracheostomy. So we talked about orthostatic hypotension. This is a autonomic testing, systolic, blood pressure, diastolic, heart rate, and this is a TIL study. So obviously this is a patient with supine hypertension, with supine hypertension and orthostatic hypotension. Still patient that could stay up without much problem for over 5 minutes. Again, they compensate, as Tom was saying before. So when do we treat this supine hypertension? And that's another tug of war sometimes between us and the primary care provider or other providers that get excited when they measure the blood pressure of the patient and the pressure is high. Yes, we don't like to have pressure super high, but we need it to be also more liberal. That's how this patient compensates. So if you correct the supine hypertension, the patient will not be able to stand for a few minutes. They will definitely collapse. So management of supine hypertension is definitely an issue for these folks. The most effective treatment usually is simply by elevating the head of the bed. That's all it takes for most folks, but not for all. Drug of choice otherwise will be losartan or things like nifedipine, although I understand I may be one of the few that still use nifedipine for this. Most people will use losartan, I would say, these days. What do you use, Tom?
I use nifedipine, sublingual great capsule.
Yeah.
Yeah.
So short-acting medication. You could try. Yep. or you can try otherwise also nitroglycerin in theory, but the problem is, again, the patient can get up at night, and then there is the tachyphylaxis where nitroglycerin and then complaints of headaches. So anyway, that's something, don't skip that, you guys don't need that. So the treatment, unfortunately, for multiple system atrophy, we always say, okay, is always supportive, fine. But there is a lot of things that we can do. If you have the MSA-P, particularly at the onset, I still use levodopa. The response is often incomplete and often transient. And yes, may worsen a little bit orthostatic hypotension, although as Tom always says, the data is overall partial and certainly is much better tolerated than we think sometimes. But there are some patients that are very sensitive and some patients that are not. So the management is focusing on orthostatic hypotension, supine hypertension, bladder care, bowel care, the tracheostomy, as we said, physical therapy, occupational therapy, and speech therapy. This is from Tom, that really had put all this together a few years back, about what happened when we give levodopa to patients. The blood pressure will drop. Generally is not to a level that will create problem in most patients, but again, if you have a patient with multiple system atrophy or with a patient with Parkinson's disease but with also autonomic failure, they're going to be more labile. So even a drop of 10 or 15 millimeter of mercury may tip them over the edge. So you have to decide how much benefit the patient is getting from levodopa, and if they tolerate it, and see how that goes. Again, most patients with Parkinson will tolerate the infusion without any problem, but the same story may not be true for a patient with orthostatic hypotension. So what's the bottom line? Try it. If the patient finds that beneficial, you can then adjust the medication for orthostatic hypotension. In most cases, you will discontinue it because the benefit is marginal, or the patient will lose efficacy. I mean, the drug will lose efficacy, and so any issue with blood pressure becomes a moot point. And I think I already mentioned this a minute. So other condition causing autonomic instability. Oh, we're talking actually at lunch about seizures and how sometimes you may have syncope or even actually cardiac arrest and severe arrhythmias as part of a seizure. So the question is, what's the chicken and what the egg? I'm glad to hear you guys are doing sometimes tilt table with EEG monitoring. We're doing the same. We had patients arriving with pacemaker, still having passing out spells. Turns out that they were neurogenic and vice versa. And sometimes until you hook the patient up by history, sometimes it's really hard to tell. And until you have everything hooked up at the same time, you can finally come up with a smoking gun. We talked about Morvan syndrome, which is one of the voltage-gated potassium channel antibody forms. There are more that are being described, that are described now. Also, some of the patients with an NMDA receptor encephalopathies will have autonomic instabilities to quite a significant degrees. Very difficult to treat patients. They've become probably one of our biggest population when I'm on hospital service. Again, we are a tertiary center, so people flock to us. Very, very difficult to treat. Other neurodegenerative disorders, classically tauopathies, generally do not have autonomic failure. So Alzheimer's disease and so forth, rarely autonomic instability is an issue. Very different from the synucleinopathies. I already talked about this, about management of autonomic storm. So let's talk about syncope in general and management of it. Well, there are different kinds of syncopes. One is the syncope due to the classic orthostatic hypotension. Then we have vasovagal syncope, vasodepressor syncope, and delayed orthostatic hypotension. Now, there is definitely an overlap among these entities, and some patients may have more than one. It's nice to see if we can identify the type, because the management is a little different, one from the other. This was an example of a patient that had a little bit of autonomic failure. You can see a Valsalva maneuver that's a bit abnormal, not super abnormal, but abnormal. There is no recovery during late phase 2. There is a lot of pulse pressure compression. Even if that was listed as normal, that wasn't. Certainly, this is a much more abnormal Valsalva, in which you have a complete loss of late phase 2. I think we have become a little bit more strict. I should make a comment about this over the years. If I go back to the prior slide, in the past we would have called this normal. Now we don't. We really like to see the blood pressure recover to baseline. Okay? And when we're talking recover to baseline, I'm talking about the mean blood pressure. Okay? So nobody would argue this is clearly abnormal. There is no recovery whatsoever. There is no phase 4 overshoot, and there is a very slow recovery to baseline, actually, of the blood pressure. So clearly abnormal. And these are patients that will eventually have syncope if you keep them up long enough. Here you see the blood pressure drops and drops and drops more gradually. The heart rate in this case tried to hold things up, but can only do so much, and eventually the patient will pass out. This is a patient in which there was no response with the heart rate, and the blood pressure drops a little bit faster. But the two things necessarily do not correlate. I have patients that completely have no response of heart rate. Think about patients, for instance, with heart transplant. They are deafferented. They don't necessarily have to faint. So here you clearly have a combination of more generalized autonomic failure. And this is a classic example of another more profound orthostatic hypotension that goes down a little faster and plummets with no cardiac responses. So vasovagal syncope, nice if you can capture on the TILT study. Heart rate and blood pressure drop at the same time. Another example, again, blood pressure and heart rate dropping at the same time. This, by contrast, is the patient with vasodepressor syncope. The heart rate stays, sometimes actually will go up in trying to compensate for the sudden drop in blood pressure, but eventually they both drop. And this,
Speak a quick
yep.
question on that
Sure.
matter. Do you see that that these patients often have a slow decline in pulse pressure that accelerates leading up to this? I mean, I just noticed in this particular one, you see that. We see that.
Sometimes you can see it. Other times seems to be, depends how quickly this happens. Sometimes you don't really have much prodrome, really. If the patient, I should say that, if the patient has enough prodrome, yes. Then you can see generally oscillations here and a little bit of the pulse pressure compression, yes. So the system is struggling. And other times I don't have it here, but we usually record also the respiration. The patient will start to hyperventilate. They kind of, when they start say, oof, I don't feel good, automatically they will start to hyperventilate, and that also will precipitate things eventually.
Before you do that slide, I think Horatio Kaufman might have published an article a long time ago saying that in every case of syncope, still there's a longer beat, longer RR. So it's really a matter of degree rather than a matter of type, meaning that everything's cardiodepressor, but just
Eventually,
very
yes.
small. If you look here, you see that there is a dip. Keep going, go, a little bit further, right there.
Oof.
There's a little dip
Well,
in heart rate right there.
But that's, well, the whole point is the patient started to take a nosedive here.
Right, but at the trough of the blood pressure.
Oh yes, oh no question about it. I mean, for passing out, eventually both the heart rate and the blood pressure drop. But
Even
the
in
question,
vasodepressor.
even in the vasodepressor, but you see that this one, clearly the blood pressure is the one leading. And not infrequently, I have patients, I don't know if I have here a tracing or not, but actually at the time when the patient has this more steep drop, there is actually a rise in heart rate transiently. The system tried to protect the patient and poof. So why are these important? I mean, are we splitting hair in terms of the management? I don't think so, because we treat the patient differently if you have a vasodepressor as opposed to a vasovagal. Not every patient responds the way we think, but you know, I think we have some rationale to argue on that. This is an example of delayed orthostatic hypotension, this very slow drop, 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 poof, and you reach a critical point and the patient becomes symptomatic.
But Paola, in that tracing, your diastolic does not even drop from baseline, right?
This one goes up actually.
Correct. And then
And
by the end of
stays
until the syncope,
until the very end.
you have not reached.
And indeed, you may appreciate that there is a significant pulse pressure compression.
Yeah.
So
So is this, when these patients have been quite delayed like this, the initial transient imbalance, non-steady state, fluid state, once you're upright, that's gone within 30 seconds or a minute?
Oh, yeah.
Right? So this is
it's a system failure. It's a system that does not, that can compensate slowly, 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 and then you're running out of that gas, I guess, for lack of a better term.
So I think I see people postulate that this might be some kind of pressure-induced transiente, that you're actually reducing circulating volume over time, but because you're losing fluid through kind of hydrostatic mechanism. But it seems hard to believe that you could.
I don't think we know for sure. And again, these patients probably are still heterogeneous. But again, if you look at this profile, as Gisela was pointing out, okay, so if I see this, when I see a rise in diastolic, I usually think of a patient that has problem with volume. But this specific case, actually, he had the transient rise here, but clearly you can see that there is a pulse pressure compression that's going on. So whenever I see that, I think hypovolemia, relative or otherwise. But could also be that the system is just not strong enough. And of course, we're keeping the patient upstanding still. So the patient does not have the typical mechanism that you will implement, moving around, pumping action, so the actual counter maneuver, as if the patient is moving around. So, but that tells us that these are patients, because sometimes we do it, if you do a tilt too short, you say, we're going to miss this patient. True. Granted, if I keep even a normal subject up long enough, still 40 minutes, there is a good chance some of us will faint. How specific is that? It's definitely going to be sensitive. But that's always the argument also when we have with the cardiologists, that they do the tilt study and infuse nitroglycerin. Well, patient fainted, thank you so much. What does that mean? But at least, you know, you can get a sense of, okay, sometimes you have this patient that tells you, I stay up, I walk, I can walk for 10 minutes, and then all of a sudden I feel dizzy. These are the kind of patients that will have this.
It seems like you hear a lot of patients that say, I do fine when I'm on my walk until I have to stop at the crosswalk, and then
poof. Exactly. So this is what might be going on.
What's the heart rate? The heart rate's not 160 at baseline, right? That's an offset.
The heart rate actually is on this scale, sorry.
But why would why would you have 0 minus 40 or something? Is that a pressure?
Oh, this, okay, this is a different scale. So we have this one that we usually monitor for the Valsalva.
Valsalva, I assume, right? That's the chest pressure.
Right.
Right.
Well, the
yeah.
So,
bellows
yeah.
pressure. Right?
So the blood pressure is on this side, the heart rate is on this side.
So that's going from 60 to 110. 100,
Right, about 100.
100.
About 100.
So that could be kind of a POTS-ish with the narrowed pulse pressure.
Started about 70, going up slowly. Yeah, but in this case, I wouldn't call it inappropriate. because the blood pressure is dropping.
Well, that's the whole question. Is the blood pressure really dropping, or is it dropping pulse pressure? So you'd have different, I mean, you could argue the blood pressure is dropping, but you could also make the argument that it's just, because the diastolic never drops below baseline, and systolic doesn't drop 20, except maybe at the very end.
At the very end. And that's when the patient...
But then you can say, well,
oof.
that's syncope. That's the syncope process happening there. It's not really orthostatic.
Well, it's very, very gradual going down. So, I mean, you can kind of see this steady trending downward.
Yeah,
and I tell you, Paula, when Tom and I read autonomic testing and we want to test, many times we disagree in the interpretation. Is it the POTS or is it
the question is the question is all the way up until minute 20, right? All up until minute 20. Is that just a narrowing of pulse pressure followed by minute 20 to 1.5? Then there is a
more
drop of blood pressure.
significant.
Well,
but here the blood pressure dropped at about 100. Yeah.
So you just barely made it.
Barely making it.
So, but I think the point of this is that this is abnormal.
This will be, to me, it's still abnormal, but this will be the kind of patient that, again, will tell you, not, ooh, I get up too quickly and oof, I have to study myself. Is the one that tells you, no, I can be up and then I'm there, I've been shaving for 5 minutes, 10 minutes, and poof.
I feel like we see people who maybe a typical criteria for POTS with a very rapid initial increase in heart rate. But then if you keep them up and they're able to sustain that long on the tilt table, you can see this, you see the big myocardial waves kick in and then a decrease in pulse pressure later. And I sort of wonder, is it different physiology should do?
No, it's probably a variant of it. And I don't know if I have here a picture of POTS, but you know, we have exactly classic POTS that jump up and go up steady, 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 steady the longer they stand. And the blood pressure may be doing something close to this eventually. And that's why at some point they will faint. But their heart rate, we're talking, goes 140, 150, 160. And at that point, the faint is probably a sudden sympathetic withdrawal.
So essentially, we're asking the same question of people with POTS who faint, who have syncope. The mechanism of the fainting, is it that they have a sudden vagal type alteration, or is it more like this, you think?
I think it's more like something like this, but there are some in which it happens very, very quickly. So it's like this final portion all of a sudden happens, but I should try to see if I have a picture on this.
This is more vasodepressant. You would call this.
This one is delayed orthostatic hypotension.
So
Let me take
the mechanism of blood pressure loss at the end here is not a loss of vasomotor autonomy.
It probably is very, very gradual.
So how does that differ from vasodepressor? Simply just
This probably is probably the speed at which this is occurring, to be honest with you. I mean, if I go back to, this one, if you dilate this segment in 25 minutes, you probably get that. So it's just a degree of how quickly things are happening.
But the big debate is whether this is in the realm of orthostatic hypotension, which gives it sort of a structural feel, or is it in a realm of
Functional side.
a functional, in which case it's really a sort of a POTS variant. It's really a narrowing pulse pressure followed by kind of a vasodepressor event.
I think it could be both.
I don't think you can tell from this graph.
Oh, yeah.
You'd have to put it in the context, let's see the whole patient, put the context of a completely normal, really robust cardiovascular responses, good debreathing, good Valsalva.
I was going to say, if your Valsalva has a continuous drop in blood pressure, then you would be worried more
Right.
that this is an
Right.
elevation.
Exactly. So if your Valsalva is if you see a Valsalva where the diastolic really drops down low, then you start worrying, okay, this is really structural. But I don't think you can tell from this graph.
So you would say the tachycardia, in the case of orthostatic hypotension, is an appropriate compensatory response.
Right.
Versus POTS, where you're saying
Yeah, it's
it's
inappropriate.
a primary.
Right, and the question is, where do you draw the line as far as when is it truly orthostatic and what is it not orthostatic? Because every patient with POTS will have an occasional little dip somewhere. I mean, so when do you call it?
Paula, can I ask you a different question?
Yeah.
Why did you tilt for longer than 10 minutes?
This one was specifically when we start looking for this delayed orthostatic hypotension. And if you have a patient that has this history that tells you, I only pass out after being up for X amount of time, then sometimes we push it. It's very
We
impractical.
always tilt for 30, but I know that Mayo doesn't. That's why I was asking you, why did you?
Generally, I go for 10, and then if I start having any suspicion that things or whatever, I do
Then
it.
you continue.
Or, yeah, or anytime the patient tells me a specific time, or if they tell me a trigger, we try to do that too, to trigger syncope. Only when I drink coffee, only if I have cold drinks. Okay, we'll try all that. So you try to reproduce as much as possible. Anyway, in terms of the management, again, depending upon what the pattern is, you can try to target things more specifically. So I see I'm running behind in time. So let's start with the management of orthostatic hypotension. So first of all, looking at if the patient can identify if they have any specific triggers, that really helps. Usually, time of day in the morning is the classic time when patient complains that the symptoms are the worst, getting up out of, in the morning. If it's hot day or after a hot shower. Some patients are very sensitive to a meal and so postprandial time. Does the type of food matter? Yes. The size probably matter most. Large carbo-loaded meal seems to also make the blood pooling worse. Prolonged standing, with here I mean prolonged standing still. When do people pass out? Waiting in line, in church, etc. Exercise. Some patients are very sensitive to exercise and making that worse. So first things first, as Tom was saying, going with non-pharmacologic intervention, so compression of the veins, counter maneuvers, water bolus. Abdominal binder, we find this to be more effective and actually better tolerated than a lot of the stockings. When I have a patient that comes and tell me, oh yes, I have the stockings on, most of the time are knee-high, that does almost nothing. The most important segment is from pretty much here, so the abdomen up to the thighs, so the big compartments where the blood can pool. Also, sometimes I tell them simply to wear Spanx that are cheaper than the compressive garments or compression sport shorts, so Under Armour or other brands of choice, usually are cheaper than other things. Problem is some of these folks, particularly the one with bad orthostatic hypotension and bad autonomic disorder, also may have problem with urgency. So if they have those shorts on and they have to run to the bathroom, they're not going to be very happy. And those things generally are warm, so in hot weather they're not very friendly. Water. We talked about increasing fluid in general. Drinking quickly 1 or 2 cups of water will raise the blood pressure and keep it up for quite some time. So that's an easy trick that people can try to use. Head of the bed elevation, 4 inches probably is the minimum that's effective. A little bit more if the patient tolerated or if the spouse tolerated without having the patient slide down at the foot of the bed, that then doesn't do any good. And no, it's not the 2 pillows. It's literally to incline the bed. So either a wedge under the mattress or a couple of bricks or cinder blocks under the bed. So the body has to be inclined, not just the head. Various medication, we'll talk about this shortly. And very important to educate the patient. As Tom was saying today, some folks have a very hard time identifying warning signs. And some patients may have very weird warning signs. But then once they start to realize it, then they know and they will try to protect themselves. And again, fluid and salt.
You find a sense of sudden fatigue?
Fatigue, every patient has, I'm trying to remember, I had one patient tell me something very, very weird in terms of symptoms. She had a very, she will have tinnitus, actually. That will be her first sign, and she will have a few seconds to sit down. But she didn't realize the first few times. When that started to happen more frequently, and she said, I always have this little whistle. I'm like, okay, that's it, that's your warning. As I mentioned, very important to compress the more proximal bed to control blood pressure. This was a study done years back and doesn't really project well. But anyway, this is the blood pressure with and without abdominal compression. So this is without and this is with, so you can see the difference is not perfect, but sure, it's enough to allow the patient to tolerate standing and not collapse to the ground. This is the effect of the water bolus. This is in patient with multiple system atrophy and pure autonomic failure. And significant improvement, a marked rise in blood pressure after gulping 2 cups of water. And you see that the effect is prolonged, so it lasts about an hour. So that can give the patient definitely enough time to protect themselves. It's not instantaneous though, so there is a little lag from the moment in which you gulp the water. It's about 10 minutes and then the pressure starts to rise.
Does this mechanism happen in normal people?
To some extent, yes, but not to this degree.
So, okay. It's interesting, almost diagnostic in some sense.
Yeah. And we talked about that. What's the effect of the head of the bed up? Reduces the supine hypertension. That's misspelled, sorry about that. And that's really very easy to fix. Physical counter maneuvers. The whole point is to raise the blood pressure by using a natural mechanism, which is basically the pumping action of your own muscle. During World War II, before there was the, the gravity suit for pilots, they were taught the M maneuver. And that was done by studies, actually, by, I'm forgetting a bunch of folks, but it was actually a Mayo. They did the study on themselves, exposed to the gravity of the G-force and the centrifuge, and it will pass out. So the M maneuver, I think they still teach pilots, although now with the new suits it doesn't matter. Basically, it's a compression. You do isometric contraction of the muscle in sequence, which is mimicking what you want to do if you want to pump the blood back up to the heart. First you contract your calves, then your thighs, then your buttocks, then your abdomen, and by then the blood has reached the heart. But you have to learn to do it in sequence. You cannot do this first and then the other, you can easily see that. But we teach at least folks to tighten the buttocks, which is a big muscle, obviously, contract the abdomen, and if you keep doing it and they get used to it, that's very effective.
Do you ever recommend Pilates for people?
I do.
I do too. Just for
strengthen the core muscles. Strengthen the core muscles and improve the tone. Other things are very simple maneuvers. These are physical counter maneuvers that you can teach folks. The idea is essentially to contract those muscles. So, and some maneuvers are easier than others, of course, but you got the idea. The effect is quite powerful. This is what the baseline blood pressure is. Counter maneuver, baseline, counter maneuver. So you see, it's definitely very, very effective. Medications. Well, Midodrine It's a peripherally acting alpha-1 adrenergic agonist. The effects is only 2 to 4 hours. Typically, maximum dose is 10 milligrams 3 times a day. First dose before getting out of bed with a full glass of water. I usually tell patient, put it by your bedstand, take a cup of coffee, cup of water, take your pill, wait half hour, then go and take your shower. Because it can cause supine hypertension, you do not want to have them take it 6 p.m. It's arbitrary, depending upon what time the patient goes to bed. At least 4 hours after the last dose. Some patients don't need the last dose. Most patients have the hardest time in the morning and early afternoon, so you can titrate the dose accordingly. Besides the supine hypertension, other side effects include the scalp itching sensation due to piloerection, the piloerection itself, and difficulty voiding, again, because it's an alpha-1 agonist. So if you have a patient with prostate problem, bladder problem, usually we tell to empty the bladder, then take the pill. So it can be a little impractical, but definitely very, very effective drug. I'm not going to bore you with the slides. And these are just simply the duration of the drug level. It's a prodrug. The actual drug is desglymidodrine, okay? And this is the drug temporal profile, and so that's why you see at about 4 hours, most patients will notice the effect wears off. Very predictable, generally, dose response. Study done years back clearly showed good efficacy. And again, I'm not going to bore you too much on this. In terms of side effects, pretty much everyone noticed the piloerection and the pruritus. Some patients notice some paresthesias. The paresthesia in the scalp can be particularly annoying. This generally is reasonably tolerated. I had a couple of patients just found the scalp itching intolerable, and so had to stop it. And the other big things, though, to pay attention is, again, if the patient has bladder problem. When do we use it? Definitely whenever you have neurogenic orthostatic hypotension. Can work in some patients with POTS that have a profile very similar to vasodepressor / delayed OH, and definitely vasodepressor syncope. I think.
So you do find a response to Midodrine and syncope?
If it's vasodepressor. Contraindication, again, it's an alpha-1 agonist, so if there is any history of coronary disease or peripheral vascular disease with ischemia, etc., you cannot use it. Questionable if there is aneurysmal disease, depending upon how bad the situation is. And it's not really contraindication per se, absolute, but you have to be very careful if you have patient with urinary retention.
Would that include patients with Raynaud's, or do you worry about that in these patients?
Not unless they have really Raynaud's with ischemia. In that case, I have patients, because as we were saying a lot this morning, patients with POTS often have Raynaud's as well. I just give them some topical, if anything, for the Raynaud's. I mean, you have to pick which is the least of two evils sometimes. Florinef, again, as you heard some of the patients, they find it very helpful. Increase the plasma volume, that's the main mechanism. There is a mild effect on sensitizing alpha-1 adrenoreceptor, so that's pretty helpful as well. Can cause some hypertension. The biggest problem is really hypokalemia and edema. Actually, the edema, in a sense, is part of a deal. You volume expand them. How much do you need to volume expand them? Most patients, if you're really effective, they will gain easy 2-3 pounds just of fluids. Typical dose is 0.1, 0.2 milligram per day.
Have you ever seen myocardial fibrosis?
I was going to ask
Never
you
seen
about
myocardial fibrosis.
I never seen it either, but it's technically one of the potential risks long term.
Okay. And it's with those doses, with lower doses, with any dose? Is it dose dependent?
I think, no, I don't think it's dose dependent. It's reported as a potential risk long term. I've never seen
I'd be
it.
curious if any, I mean, we use a lot of it. I have never seen it. Now, of course, I don't look for it.
That may be also one issue. Frankly, I've not done it myself. Pyridostigmine is it's an easy drug to use generally. Basically works like the amplifier in your stereo, improves the ganglionic transmission by magnifying the preganglionic signal. Is not super powerful by itself, but for some patients it's sufficient. Otherwise, you can use it as a midodrine sparing agent. And the biggest thing is does not have any problem with supine hypertension. So
Do you use that always as the short acting, or do you use it?
I usually start with the short acting, also to get a sense how much side effects, diarrhea essentially, they get. It's a lot cheaper than the time span. Then if they don't tolerate the dose, the short acting or whatever, I go to the long acting. But most of my patients are on a short acting actually.
But I don't think long acting works.
I was going to say, I had a couple of patients that did really well with the short acting, and we just decided let's try the time span. And it
Well, the time span, it's, even for myasthenia, it's a very bizarre, and it's not, 180 equate to really 120, so I don't know. I've only had one patient, frankly, well, no, 2 or 3 at the most, that really preferred the time span. So I don't really use it much. Well, I'm not going to spend much time on the results of this. I mean, definitely works.
I think it's great when they're constipated too.
So, in reality, this is a drug that for our classic MSA, pure autonomic failure, etc., they have constipation. It's a fantastic drug, kills 2 birds with 1 stone. Doesn't work so well if you have a patient with POTS. They may have more predominantly IBS diarrhea type. Although I also had patients that already had problem with diarrhea, and the mastine doesn't seem to make any difference. So anyway, it's a very easy drug, old, good one to start with. The RoxyDopa now is available. It's again hydroxylated levodopa. It's converted by dopa decarboxylase to norepinephrine. So seems to have both a direct and an indirect action. It's unfortunately very expensive, but it's strongly supported by the company. And so if you have patients that cannot afford it, or the insurance, I should say, doesn't pay, the company will basically make the patient pay us. It's a copay of $50 a month, if that. So seems to have pretty good effect on OH with relatively less supine hypertension problem compared to Midodrine. And it's a mechanism of action. So as a direct action on alpha-1 adrenal receptor, and also indirect in the sense that will replete the adrenergic terminals. So should be, in theory, more powerful. I think the jury is a bit still out if it is more powerful or not. Let's just skip this.
Is it a direct agonist, a full agonist of the alpha-1?
Well, it's norepi, basically. It's converted to norepi.
Oh, okay, so I thought you were suggesting it also had a second agonist, so it's not.
No,
it's always through.
It's a direct, and then in the sense of also replenishing the intron, so at the end of a terminal. So you have a direct effect, and you restack the neurons that's depleted. Very important. Yeah.
Any data coming out of RoxyDopa for POTS?
I have not used it in POTS
Neither
yet.
have I.
No, they were planning studies, but I don't.
Yeah, Julian's doing a study.
Well, I know there are studies, but there is
Okay.
no.
No data.
I have used it in 2 patients with POTS.
Has it worked?
Yeah, it's very effective.
Well, I've used it a couple of times also in a patient that I should not in theory have used, because it was a patient with diabetic neurogenic orthostatic hypotension that has failed everything. One of those disaster young patient, and he responded magnificently to RoxyDopa. So I'm doing it off-label.
Do you think it has any effect in the adrenal system, it's all peripheral, based on the, I keep getting back to this idea.
Well, I think,
Well, wait, the adrenal, you're talking about producing more epinephrine in the adrenal?
right, this is norepi.
The norepinephrine is what, 28%?
Yeah, right.
So, you know, there are effects of circulating norepi directly on the vasomotor tone.
Right.
So I'm just wondering if it would enhance circulating norepinephrine levels, even in somebody who had maybe significant neuropathy, not having any peripheral fibers there.
It should, in theory. But I don't think anyone has specifically looked. Anyway, very important to educate the patient, to learn how to recognize the symptoms, prevent them, and basically cope with the condition. And some patients are very sensitive, as I said, to heat. Some patients are very sensitive to meal. Other patients are not. So we teach them to avoid standing too quickly. I usually tell them also to maybe stomp their legs before standing up. We teach them how to do the water bolus. We teach them counter maneuver. We let them play with their dose of medication a little bit. Not every day is the same, and sometimes they may need to adjust their timing or have extra dosing, etc. We have them try to have a blood pressure log, particularly if they don't have a good sense of their highs and lows. Some patients are very good in detecting that. Some patients cannot feel it. In terms of how much salt, we can actually measure plasma volume. It's a little bit more costly, though, than 24-hour urine sodium. We usually shoot for at least 170 and up millimole for over a 24-hour.
Recent recommendations have been higher.
Now we're going to be high. So that's what originally we did. I usually go almost empirically sometimes until the patient has gained 2-3 pounds or they start to have some puffiness at the ankles. So lots of fluids.
At that point is when my patients stop the meds because they don't want the weight gain.
So do you, I saw you have the blood pressure log, and I've had people do that, but I was tempted, I think that the idea of having people follow their weights like they do in heart failure clinics, have you tried that? Has that been something that's useful, or is it easy?
Well, usually it's an initial gain and then they should plateau.
But you would think if, for example, they had a kind of a catamenial diuresis, or mental diuresis or something like that, that you could pick that up. But maybe that's not something.
I haven't asked them to do that. And some patients, yes, but this is really OH. The catamenial thing is more like patient with POTS. Sometimes they get worse. Usually this group is a little older, so it's not an issue. This is what we generally tell to do. I usually like to have a 24-hour blood pressure, which I realize is something that cannot be, however, achieved very easily everywhere, and I couldn't tell you why. I like to have a 24-hour because it tells me not only what the patient does during the day, but also if they have supine hypertension, how much. Most of them are non-dippers, so get a sense how dangerous their hypertension may be at night. That helps me.
Do you run the blood pressure monitoring? Is that something that you do through cardiology?
I do through nephrology and hypertension. And I usually ask for the heart rate and the blood pressure 24-hour together. So this is, again, what we do. Let me just say a couple of things about postprandial orthostatic hypotension. Usually the recipe is frequent small meals, some dietary modification. As I said, large carb loading is the worst. Sometimes ibuprofen with a meal. Why? Sensitize adrenal receptors. Caffeine with meals. Putting a dose of Midodrine strategically before meals. Octreotide is very expensive. Acarbose. Huh?
Ibuprofen sensitizes adrenal receptors.
Yeah. We use that also before exercise for people that have exercise-induced hypotension. Really?
Ibuprofen sensitizes adrenal receptors. Alpha?
Alpha.
So, because I know Florinef does that.
Yeah.
Low dose. But I didn't know
This
Ibuprofen
is-
does that.
Apparently every NSAIDs can do that. So, and acarbose. Acarbose, postprandial hypotension. This is supine hypertension. These are the options. Reduce the fluorocortisone. Head up. Head of the bed up, as we talked about. If people like to have a glass of wine, that will be a good time to have it before dinner to vasodilate them. And medication, as we talked about, losartan. I've not used hydralazine myself, but technically use it. Procardia or equivalent. Is radipine too, and nitroglycerin, that's still an option. Inpatient treatments, that's the only time I generally use IV. I don't use IV otherwise. Strongly discourage the central line and ports. Too much issues with management, the risk of infection, and so forth and so forth. How about I stop here, because the rest was on management of like bladder, bowel, which I think we can do another time.
And we're going to have some.
And other people will do it.
Conversations about that.
And so.
So does ibuprofen work in somebody's incontinence? Because it would increase the.
I don't think it's that powerful. I don't think it's
But I
that
mean, it might give
powerful.
you a little bit of an edge.
Worth a try. I frankly have not done it. I generally use it, I tell you, mostly for people with exercise-induced hypotension. That seems to work the best. But in theory, it could work for these other folks as well. So.